Buenos dias. Good morning. Welcome to the headquarters of the U.S. Department of Health and Human Services. My name is Dr. Sean Bruna. I'm a senior advisor to the director of the Agency for Healthcare Research and Quality, otherwise known as AHRQ. I use he, him pronouns, and for those with visual impairments, I'm Latino with brown and gray hair, dark blue glasses, and today I'm wearing my DC uniform, a black suit and a tie. On behalf of HHS and AHRQ, I'm honored to welcome you to today's summit to address emergency department boarding. We're excited that you're joining us in person and online to learn about and address this important issue. But first, some logistics for today's event. There are staff throughout the room. Should you need anything, flag one of us and we'll help you out. You'll notice the badges on us. Bathrooms are easy to find. Walk to the back of the room, take a left, signs will guide you there. Today's summit is being live streamed, and a recording will be shared on the HHS YouTube channel in a few weeks. You can find it at HHS.gov/live. And you can join today's conversation in two ways. You can follow us on Instagram and X at AHRQ News, and on LinkedIn and Facebook by searching for the Agency for Healthcare Research and Quality. I recommend using the hashtag AHRQ to bring us all together in the online conversation. You can also email your comments and thoughts to us at AHRQsummit at AHRQ.HHS.gov. Today, you'll notice we also have Alejo Porras, a live artist from the Sketch Effect. He'll be actively listening to today's sessions and creating drawings of the big ideas in real time. Feel free to check out the boards after the session, and we'll be sure to share digital copies sometime after the summit. Dr. Robin Wennick is our facilitator for the day. She's an executive coach and consultant who helps purpose-driven leaders and teams work more meaningfully so they can deliver the health outcomes that matter to patients and the public. She works with leaders and teams from the C-suite through directors, with an emphasis on leaders in academic medical centers, state health and public health departments, health providers, and organizations that lead innovation in the healthcare delivery space. Dr. Wennick's career began with a decade of work here at AHRQ, followed by her serving on the faculty of Massachusetts General Hospital and Harvard Medical School, and holding leadership roles in healthcare research at RAND and RTI International. We welcome Robin back to AHRQ to moderate today's session. But first, it's my honor to introduce Dr. Bob Valdez, the Director of the Agency for Healthcare Research and Quality. Dr. Valdez?
Good morning, everyone. I'm really delighted to welcome you to today's AHRQ Summit to address emergency department boarding. For those of you who haven't visited the Hubert Humphrey building, which is the home for the Department of Health and Human Services, around the wall you'll have the portraits of the secretaries of the Department of Health and Human Services. And a new addition is our real serious effort to listen to the native nations of our country, and the flags that are represented above are the flags of the representatives of the Secretary's Consultation Council, and we meet with them on a regular basis. They, like many of us throughout the country, experience the issues around emergency boarding. Many, because they live in rural communities, experience extraordinary issues around boarding because rural aspects are often forgotten about. Those of us who live in urban settings and urban cities have a particular experience with emergency department boarding. Just out of curiosity, how many of you have had either a personal or family member experience emergency boarding? Almost everybody in this room, for those of you who are watching online, have raised their hands. I too had an experience not long before I took this position. One morning I woke up in severe pain in my stomach, so much so that I was bent over, and my wife took me immediately to our to our primary care clinic. The primary care clinic said, "Oh, you need to go to the hospital." And my primary care provider said, "You know, I don't recommend that you drive there. It's only a quarter of a mile from here. Let me call you an ambulance, because if you arrive in an ambulance, you'll come in the back way and you'll immediately get seen in service." So they call an ambulance. I'm taken a quarter of a mile away. I get right into the emergency department, and I'm there. I'm there 5 hours, 6 hours, 7 hours. I'm bent over in severe pain. They give me some medication for the pain. I'm still in severe pain at 12 hours, 16 hours. And in the meantime, during those 16 hours, other ambulances were arriving. And for those of you who are emergency physicians will know, well, if there's blood, they go to the head of the line. So there was lots of blood that night by the time I was coming. Eventually, about 2 o'clock in the morning, they sent me up to get some images. And not surprisingly, it was my gallbladder. And it was about to burst. So they said, "Well, you need surgery immediately." So they put me on a gurney and rolled me into the backside of the emergency department in a hallway. Hour 20, hour 23. A surgeon shows up and can take me. 24 hours after I arrived at the emergency department, I finally had my gallbladder taken out. And I can't tell you how relieved I was because the pain finally went away. But that's a story that goes on daily across the nation, and that unfortunately many of our emergency department physicians have to deal with. Patients in hallways, patients in gurneys sitting waiting for either a surgical suite to open up, a bed to open up, but it's something that all of you in this room who raised your hand know firsthand how difficult that is, whether you're the patient or whether you're the loved one who's there to help your patient get through the journey of healthcare in our country. Last year, 44 members of Congress sent a letter to Secretary Becerra expressing concerns about patient boarding and the crisis that they saw in their communities' emergency departments. They requested that he set up a task force of key stakeholders throughout the healthcare system to be convened to identify immediate and long-term solutions to this critical issue. Setting up a task force would have meant we would just get started today, probably, and that was about a year and a half ago, 2 years ago. Instead, Secretary Becerra turned to AHRQ to convene a series of consultations more rapidly, culminating in today's event. Our goal for today is really to identify actionable next steps and novel opportunities to chart a public and a private strategy to address the daily crises that emergency departments across the nation face. And it's that public-private partnership that allows us to make the kind of medical progress and systems improvement that we need. AHRQ has supported work to improve emergency department care for many, many years. For example, in 2007, we helped support the National Academy of Medicine's report, The Future of Emergency Care in the U.S. Healthcare System. Earlier this year, we had a roundtable of healthcare systems leaders, emergency department professional societies, payers, and of course our federal partners, who I can't thank enough. Our partners at CMS, our partners at ACL, our partners at HRSA and at SAMHSA, all of whom allowed us to begin a broader discussion about what ED boarding meant post-pandemic. At the Academy Health annual meeting in June this year, we gathered a panel of emergency department leaders, some of whom are here with us today, and health system and health services research community to really explore the dynamics that are driving the ED boarding in the post-pandemic era. This summit is another step in our efforts to convene leaders from across the nation to identify ways to resolve the issues that we face in emergency departments and in health systems. ED boarding kills patients, with direct associations found between length of boarding and mortality. But it also leads to other issues: increased ambulance diversions, increased adverse patient and workforce events, preventable medical errors, lower patient satisfaction and clinical staff burnout, violent episodes in the emergency department. I can tell you my wife almost got really violent in that department when I couldn't come out. And higher overall healthcare costs. At the outset of this summit, it's important to define ED boarding and what it isn't. ED boarding for us refers to holding admitted patients in the ED while they await an inpatient bed. It's not a new issue. We've been discussing this issue for more than 25 years. And it has come into focus more recently during the pandemic because EDs served as a major entry point to the healthcare systems for COVID-19 patients and became visible for all to see. According to a November 2022 American College of Emergency Physicians survey, 97% of ED physicians said they experienced patient boarding at times of more than 24 hours, similar to my story. Some 28% said patients were forced to stay in the ED for more than 2 weeks before getting a hospital bed. Now, boarding is really about high acuity patients who need to be admitted to the hospital and need to be served and receive the services of a high performing institution. And very importantly, I think it's important to recognize it's not a problem of emergency departments. Boarding is a symptom of a system breakdown in the local healthcare delivery system. In addition, it intersects with other local healthcare, other local needs, housing needs, healthcare access, and a host of other factors outside the walls of the emergency department. It's time to turn the ED boarding crisis really into an inflection point and to find real, implementable solutions to these issues. And today, we will consider many of them, such as how to measure the issue appropriately, how to align payment structures and incentives, how to redesign workflows and staffing, but always, always, always to be mindful of preventing staff burnout by providing adequate support. This summit is an opportunity for a collaborative blue sky discussion, and we hope to learn about needs and topics for future activities sponsored by AHRQ and other federal partners. With you and others in our nation's healthcare systems, we can't go wrong, because it's through that partnership that we'll actually make progress. And I want to highlight one of those partnerships, the leadership of the American College of Emergency Physicians, which has worked tirelessly to bring the issue to the forefront. Last fall, the discussion at the ACEP Summit inspired us and others and provides a foundation for our work today. And I look forward to getting to that work immediately. Robin, get us started.
Thank you, Bob. We're one microphone short, so you'll need to do a little bit of sharing. I'm delighted to be here with you all this morning to discuss this important topic. I have a few important jobs. One of those, of course, is to introduce our speakers. The other, though, is to keep us running on time. So we'll make some time for conversation among our speaker panels, as well as for some questions from those of you who are here with us in the room. If you're here with us online, as Sean shared earlier, you can email your questions in, and there's someone in the room who may be able to share them if we have time. So I'll start with some introductions. Immediately to my left, Chris Dellinger is the 2024 president of the Emergency Nurses Association. And Chris Dellinger has spent nearly her entire career in emergency nursing as a staff nurse, charge nurse, coordinator, trauma services manager, and state trauma surveyor. And she's currently the director of emergency trauma and ICU services at WVU Medicine Camden Clark Medical Center. Thank you for being here, Chris.
Thanks for having me.
To her left, Dr. Brandon Morchetti is a physician who's dual board certified in emergency medicine and emergency medical services. He serves in urban, suburban, and rural communities throughout Arkansas and Texas, and as the medical director for the Air Evac Life Team for the state of Arkansas. All of the Arkansas state parks, so we know we're in good hands if we go hiking, and is the assistant medical director for the Metropolitan EMS in Little Rock. Dr. Yula Huang is an emergency physician and researcher at Yale School of Medicine, interested in the quality of emergency care that older adults receive. She co-led the development of the 2014 Geriatric Emergency Department guidelines that are endorsed by the National Emergency Medicine and Geriatrics organizations, and serves on the Board of Governors for the American College of Emergency Physicians Geriatric Emergency Department Accreditation Program. And to her left, last person joining me on the stage, is Dr. Charity Watkins, a tenure-track assistant professor in the Department of Social Work at North Carolina Central University, and a Duke NCCU, do I pronounce it Birch Scholar? It's one of those acronyms. Y'all know about the acronyms. She holds a PhD in social work from the University of North Carolina in Chapel Hill, and her research is deeply influenced by her personal experience with peripartum cardiomyopathy, and focuses in part on how social work can interrupt racial inequities in healthcare treatment and to treatment of cardiac-related severe maternal morbidity. Before we turn to the panelists on the stage, though, I'd like to introduce to you someone who could not join us today due to a conflict. Rosie Bartell is a patient partner, a widow, grandmother, and an educator. And in August 2009, she underwent a total right knee replacement and developed a MRSA staph infection. Ms. Bartell believes in helping others with disabilities and other health concerns to find their voices, and she uses her own story, which we're about to hear, to co-design with medical professionals and researchers and to advocate for patients and their caregivers. Can we show this story? Rosie was kind enough to share her story with me in advance since she couldn't join us today.
Hey, this is Robin. I am actually going to be watching this video along with people in our audience at the Emergency Department Boarding Summit. I'm sorry you couldn't join us in person today at the meeting. I'm so glad you're taking the time in advance, though, to tell us a little bit about your story so people can understand the human impact of what happens in the emergency department. So I'd love to start. Can you just tell us a little bit about the context of where you live, what the healthcare is like there, and the hospital that you're going to tell us about?
Sure. First, thank you for inviting me and sharing this video with the audience. The community I live in is a very small community. The hospital is a 21-bed access hospital. It has a very small ED department where a doctor comes and goes every shift. So basically, a doctor is not there all the time. There is an RN on call, or an RN there all the time. The doctor also is responsible for the whole hospital when he shows up. So it's not just being responsible for the hospital, for the ED, but also for the hospital. Also, at this point in the time of our community, we had no community doctors. And we had one community nurse practitioner, and she was out on a maternity leave. So basically, this was a doctorless point in the history of this community.
Wow, that sounds like a huge challenge to begin with. And then tell me what happened with your mom going to the emergency department and what that experience was like for both of you.
Sure. Well, my mom lived in a skilled nursing home very close to my home, like 5 blocks away. And that skilled nursing home was very close to the hospital. So about midnight, I got a call from the hospital, from the skilled nursing home, saying that my mother was having problems with breathing and her wound was looking really bad. And so on her leg, the wound on her leg. And so they were going to call the ED and have her taken, the ambulance, and have her taken to the ED. And I said, I will meet her there. And so it took me about an hour to get to the ED. When I got to the ED, my mother was in a room, and when I opened the door, it was a room right next to the garage where the ambulances came in. And so she right away started screaming at me that, Mom, why did you put me in the garage? And my mom never, for the last 4 years of her life, she thought I was her mother, not her daughter. And I said, I didn't put you in the garage. You're in the ED, you're in the emergency room. This is not a garage. And so she said very quickly that nobody was listening to her. And I said, what do you mean? And so then I went over to look for her call light. And I couldn't find a call light on her table and tray. And so I went down to the desk and I said, where is my mother's call light? I said, I can't seem to find it. And they said, we took it away from her because she was abusing it. And I said, she's an Alzheimer's patient, so she's agitated, and so I think that's why she's probably abusing it, because she thinks she's in a garage. Well, that began the 4-day stint of being in that ED.
4 days.
4 days, yes,
Yeah.
4 days. Every day, we would hear ambulances come in and go out, and the ambulances would come in with broken legs and contusions and things that needed to be stitched and sewn up, and all of these people were taken ahead of my mom because they said eventually she'll need to be evaluated, and we think she's going to have to go into the hospital because she seems to be having some infection in that leg. Well, after the 4 days, she started to develop what I considered the signs of sepsis. And I think that's why they finally, after 4 days. But during those 4 days, the first day, she didn't even have water. And eventually I just said, and they kept saying, well, we don't know what test we're going to run. So we don't know if she should have water or food. During the 4 days, she had absolutely no food. They made her use a bedpan, and that got to be a real interesting situation with an Alzheimer's patient who thinks she's in the garage. So it was just, some days it was, sometimes it was comical, but many times it was very stressful, especially on myself and my husband, who came and went. But because I wanted to keep her calm and keep her under, under some control, and yet I was not happy because they were not seeing her, and the ED doctor would come and go, and every time she was not the priority of the moment.
Yeah, that sounds very, very challenging. Can you tell me a little bit about the impact this had on your mom and her health and on you?
Well, my mother's, when she finally got to a regular room after the 4 days, she still didn't believe she was in the hospital. She thought she was still in the garage. And then when she went back to the long-term care, before that, she always felt like the long-term care was her home, and she treated it like her home. And she would say things like, everybody came over to play cards today at my house, and those kind of things. And I always called her my happy Alzheimer's patient because she just had a very positive attitude about it. But once she went back, she kept saying I was leaving her, and she felt like I, as her mother, was leaving her in this terrible place because she just didn't believe that it was the same place that she came from originally, because she forgot that this was her home.
Sure. And you spent 4 days sitting in an emergency department while waiting for her to be evaluated and admitted.
Right. Yes, and during those 4 days, and I'm also in a wheelchair. I'm an amputee, so I'm having my husband bring me clothes. I'm using the hallway bathrooms to change clothes, and even for me, hallway bathrooms are not the place I always want to be, especially emergency room hallway bathrooms. They're in this hospital anyway. They were very small, and I mean, more than once I got caught on the call light and set off the call light in the because I would get caught on it with either my wheelchair or like trying to change my clothes.
Yeah. Well, Rosie, thank you so much for sharing your story. I'm sorry this is something that your mom and you had to go through, and hopefully the conversations during this meeting will lead to an improvement in what happens out in the real world with emergency department care.
Right, and I believe also emergency departments in small communities. I don't think always we understand what rural communities go through sometimes.
Yeah, thank you for sharing your story.
Thank you, Robin, for inviting me.
Well, thank you again to Rosie. Sorry she couldn't be here in person to join us. We thought it was important to start off with a patient story and really hear about the day-to-day impact. Not that you all don't know it, but it's, and in fact, Bob asked you a few minutes ago to raise your hands if you had had a personal or family member experience emergency department boarding, and the vast majority of people in the room did. And yet hearing a patient story in a setting like this is really powerful and especially important. So to open up our conversation, I'm going to turn to Brandon, if I might. You warned me in advance that you were going to be our doomsayer this morning. So tell us a little bit. I know there are a lot of programs designed to keep people out of the emergency department. And can you tell us a little bit about them and what's good about them, and yet at the same time, how do they affect emergency department boarding, if at all?
Sure, yeah. No, I promise I am normally a positive person, but I guess just kind of describing the state of the affairs today is going to put me as the doom and gloom guy. So programs that currently exist or have come and gone in the past, there's patient education, of course. We try to educate patient what's an emergency versus what can follow up with primary care. I saw a billboard the other day, step on a bee, go to an urgent care, step on a beehive, go to the emergency department. There's expanded telehealth options, trying to expand primary care hours, extended hours, weekend hours, things like that. Mobile health units, home health programs, hospital at home programs, trying to keep admitted patients, in their own bedrooms and living rooms at home. There's programs to address social determinants of health, a lot of transportation issues, trying to get them to their primary care appointments. There's chronic care management, outpatient mental health services that are expanding. Of course, increased number of urgent cares and freestanding EDs, nurse triage lines, community paramedics, mobile integrated health, the now shut down ET3 program that stopped a couple years early last December, and then the transport to alternate destinations and treatment in place programs for EMS. So many programs that are currently in existence or that have been tried and not successful, and the reason I think is multifactorial. They're, from a 30,000-foot view, the patients, there's just too many. EMS patients, for starters, are only about 15 to 20% of what comes into an ED in the first place. And for the last 6 decades, EMS has only been paid to transport a patient from where they pick them up at to the most expensive and overwhelmed resource, the ED. And there's not really, with rare exception, there's not really good programs to reimburse them for doing anything other than that. And so they're not going to take a patient somewhere where they're not going to be able to make any money off that to pay for their operational expenses. So that's the EMS part. For the outpatient world, there's just not enough primary care physicians. Their reimbursement is not great. They are not having enough expanded hours to be able to handle the sheer volumes. If you wake up with flu-like symptoms this morning, you call your primary care doctor, they say, yeah, we can see you in about 3 weeks. That's really not going to help you. And so in the ED, we are a victim of our own success. Hey, come in here, check in, we'll see any anyone, anytime, with any problem, 24/7, 365, regardless of your ability to pay, because we're the only medical subspecialty in the House of Medicine that is federally mandated to see every patient that asks to be seen. And we'll get you your diagnostics and make you feel better pretty quickly. And that is what we do. We can give patients those quick answers and that quick relief. And so they know that, and they'd rather come see us and take advantage of that. Also, we know that despite all these programs, the number of ED visits over the last 20 years have still gone up about 40%. So there's just an increased number of patients accessing the system entirely.
40% increase in 20 years in emergency department visits. That's just way disproportionate to healthcare utilization and any other sector that I know of.
And to make that worse, over the last few years, there's fewer staff to see those patients.
Yeah, I understand that I think it was in 2020, the 2022 residency match was the first time that emergency medicine did not fill all of its slots, and that it was even worse with the 2023 match. So yeah, it's very disturbing. So can you talk a little bit about the impact of boarding on EMS and on public safety? EMS is such a unique system, right? And it's this odd, some cases it's private, in some cases it's attached to the fire department, in some cases it's an independent agency, and there's a lot of complexity around that.
Yeah, I think I see a lot of familiar faces here in the room. I'm sure online, very familiar with the fact that ED boarding is not just a hospital or ED problem. It definitely trickles outside the walls of the hospital. And so and a patient comes in on an EMS stretcher, the expectation is there's going to be an available bed, and that patient will be transferred over to that bed and turned around back out on the streets within about 20 minutes. Over the last few years, that goalpost has moved. Now 30 minutes is the norm. 45 minutes to an hour is becoming the new norm. And the National EMS Information data, the 2023 data set with over 50 million EMS records shows that about 20% of those patients transported, it's over an hour that they're waiting on a stretcher. 1 hour is now the new norm. And there's several instances on a day-to-day basis around the country where 2 to 6 hours is common. There's case reports from the West Coast, 24 hours waiting on an ambulance stretcher, not a hospital bed, an ambulance
So the
stretcher.
ambulance and the crew are still sitting in the emergency department because the patient is on their stretcher.
Yeah.
So that's 24 hours that they're not attending to other calls.
That's correct, yeah. And so that delay in transition of care, it leads obviously to compromised patient care, worse patient outcomes. You get diminished patient experience. The disruption of continuity of EMS services. So that crew is not available to make the next 911 call. There was an article that came out last week that had a patient story. He was having an active heart attack and was on the phone with 911 waiting on an ambulance for an hour, and that ambulance was held up at the hospital. And so the ambulance is what makes the news the next day, not the hospital that delayed that ambulance from responding to that call. It leads to threats to our public safety, the ability for EMS to respond out there, the resiliency of that community to respond to emergencies is diminished because of hospital bed delays. And I say hospital bed delays intentionally. It's not EMS bed delays. It's not our beds. It's the hospital's beds. And I say that as an ER doctor. Obviously, I'm holding up some of those patients as well. The EMS crews, it leads to burnout for them as well. Mistreatment for them. You bring in a patient with a mental health emergency that's stuck on your stretcher for a few hours. It's the EMS crew that gets hit in the face, not the hospital crew. So fighting that patient more. Hospitals can go on diversion or delay and prevent ambulances from coming for a few hours so they can get a break. You cannot do that with the 911 system. We don't get to say, well, we're pretty busy, so we're just not going to take 911 calls for the next few hours. So it's not an option for EMS, and it leads to a lot of frustrations within the pre-hospital system.
Thank you. And I should have mentioned earlier, as you all have questions for whoever I'm speaking with, please chime right in. So one more question for you, Brandon, which is I would love to hear your perspectives on the impact of boarding on emergency department physicians.
I see lots of physicians in the room here, and I'm probably going to see some head shaking, but it's no secret that we all took a beating during the pandemic. Long hours, getting sick, exposed. I saw a report out of the AMA said 622 more physicians died than were expected to have died in a normal year during COVID. The ED overcrowding and boarding obviously led to more incidents of physical violence against nursing and physicians. I personally was assaulted twice by patients. Physicians swing too, but by patients who now are serving multi-year jail sentences after pressing charges, and that's not something that we ever would have thought would have been a thing. Year after year, emergency medicine leads the way in burnout. So I think the last number I saw from Medscape was 63% reported burnout. The average across all physicians is about 49%. And year after year, emergency medicine is about 10% more than the second most burnt out specialty, which changes, but usually it's a lot of primary care specialties. But overall, about 3 times more likely to experience burnout as an emergency medicine physician. 2022, there were 219 unfilled positions, and that was unheard of. And then 2023 was 554 unfilled emergency medicine positions in the residency match. So I think graduating medical students looked at that and said, yeah, I don't think that sounds like any fun. I don't think I want to do that, and then choose a different specialty altogether. Luckily, 2024, we rebounded. There were, I think, about 135 unmatched positions, but not near the heyday that we had a few years ago. And then I'll end with just one story. So Super Bowl Sunday 2 years ago, 2022, was working at a critical access hospital, 7-bed ED. I'm the only doctor in the entire county. Had 3 patients in the ED that night. That one was a spontaneous hypertensive head bleed, herniating, intubated. Second room next to them was a flash pulmonary edema patient on BiPAP and a nitro drip. And then the third room right next to that was a gentleman who had gallstone blocking his bile duct and had ascending cholangitis, septic on pressors. I'm a 7-bed ED in a critical access hospital. There's no specialist there. And I called 25 different hospitals across 5 different states that night. I know there were open beds. There were just probably no staff for those beds. And those 3 patients sat there all night long while I finished a 24-hour shift and signed them out the next morning. And I just remember thinking, this can't be American healthcare. I'm talking to the family, trying to explain to them as gently as I can the failures of the system, that these patients are going to have bad outcomes because I can't get them out of this critical access hospital. And that leads to moral injury among emergency medicine physicians. It's a threat to our safety. That's risk and liability we take on ourselves. It makes you not want to come back the next day to work. But then if you don't, who else is going to do it? So we do it anyway because that's who we are. And it's just the compounding day after day over the last few years. So I promise I'm a positive guy. Just not this morning as doom and gloom.
Anyone on the panel have questions for or comments on what Brandon has shared? We'll come to the audience questions in a little bit. So I'm actually going to turn to Chris, if we might, and stay with the theme of people working in the emergency department. So I'd love if you could talk a little bit about the impact of boarding on the care that nurses provide to patients. I know, obviously, this is a topic you're intimately aware of on a day-to-day basis.
Absolutely. So as Brandon mentioned, we have the issue of taking care of the boarded patients within the ED, as well as those emergency department patients that present, because as you know, we can't lock our front doors. And so boarding for us can be hours, it could be days, it could be weeks, sometimes months. And an ED nurse is not equipped from an inpatient perspective to take care of those inpatient patients, and those things can get missed for those patients, which can lead to increased mortality and morbidity. And so a lot of what he was mentioning is a lot of what we face on a daily basis, is we do face a lot of burnout. I actually was just having a conversation this morning as we no longer have tenure within our emergency department from an emergency department nurse perspective. If we do, you might have a 25-year nurse, and then most of our nurses are 3 years or less that's in the emergency department. And so that also adds to a safety perspective as well, because the sheer volume of patients that you take care of, your ratios can really increase on a shift-by-shift basis. Most emergency departments are a 1-to-3, 1-to-4 ratio from a nursing perspective, but you add a boarded patient into that mix and you can start taking care of 1-to-6, 1-to-7, and it's not unusual to have 2 or 3 critical patients in that mix as well. So it really has impacted nursing as much as it has an ED physician perspective.
Yeah. So it sounds like from both a physician and a nursing perspective, the ED is not just serving an inpatient function, but also an ICU function.
Correct.
Yeah.
Yes.
Yeah, that's got to be an enormous challenge on that. What are nurse staff ratios in an ICU? 1-to-2?
1-to-2. Mm-hmm.
Right? And
Yes.
you're talking about instead 1-to-6, 1-to-7, right?
It just depends on the situation.
sure.
And like you said, critical access hospitals, they have lots more limited resources than more of your academic or tertiary centers, but they're also facing their own challenges as well from a nursing staffing shortage. Because one of the things is from a nursing perspective up on the floor, they can close beds because they don't have the staff. Whereas in the ED, you don't close beds. You take care of those patients and you do the best that you can. And part of the difficulty, as you mentioned, is trying to explain to the patients and their families, we'll get you out as just soon as we possibly can, and just hoping to be honest and transparent with them. But sometimes that lasts weeks.
Yeah. And what about the impact on nurses? Can you tell a little bit of a story? And just your sense of obviously tenure is a big impact. Instead of being able to continue to attract 25-year experienced nurses, you're now dealing with an average tenure of 3 years. But what is the impact? What does it really feel like to be a nurse in the emergency department now compared to how it used to be?
So I've been an ED nurse for 30 years, and when I started 30 years ago, we didn't have this situation. You can really go in and take care of your patients and do all the things you needed to do. And then fast forward to when COVID hit, and then where we are currently today. With COVID, beds were very short then as well, and from a nursing perspective, we were taking care of those patients for long hours, and so we were basically doing the inpatient perspective at that time as well. And then to today's world, we are very busy. It's hard to really provide the good quality care that you want to provide as a nurse. As a nurse, I love taking care of people, and I want to do the best I can for them each and every day. And I do the best I can, but sometimes that's hard to be able to be with the patient that is on their call line all the time, whereas you're trying to take care of the MVC that just came through the door that needs intubated, needs lines put in, needs several drips. From an ED perspective, you're about the acute stabilization phase and need to do that. But you also have the other patients you have to take care of as well. So burnout is real within emergency nurses. We do see the turnover happening more and more frequently than we used to see, which is very unfortunate because ED is my passion. It's what I like to do, and I really try to create folks to come to our department to work, but the demand and the pace is hard to keep up with.
And what's the impact on recruiting for getting nurses in the door to come join you?
So a lot of what I just mentioned is hard to recruit nurses. I will tell you, as a new nurse these days, you actually can come right to the ED, whereas years ago you had to have med-surg experience or critical care experience before you could ever apply to work in an emergency department. Well, that's not the case today. You can come directly in as a new grad. I actually, in my own emergency department, I have 11 new grads currently right now orienting within my emergency department. I'm happy to have them, excited to have them, and to watch them because they're excited to be there. and really want to keep that momentum, and just hope that we don't create that burnout. So retention is hard. We try to be creative. We use what's called ED user councils and really bring in the frontline staff to come together to help us solve solutions and what can we do in real time, because they're the ones doing the work every day and really trying to come up with those solutions. And so for them to have a voice has really been impactful for us, and we're starting to see that more and more from a shared governance perspective.
That sounds like a big shift compared to, what I think we all tend to think of emergency departments as having a command and control history, right? That's right. Sort of how things used to be. So what are the kinds of issues that they're bringing to that users council?
So, for example, flow obviously is our biggest thing, and as Brandon mentioned earlier, boarding is really a hospital issue. It's not an ED issue. So how can we help our partners upstairs, and how can we help them understand what we're facing within our ED? So we've been doing looping experiences. So to have the inpatient nurses come down and spend a couple hours with our ED nurses and vice versa, so we can really understand. And when we want them to take the patients and not to give us grief and to go ahead and take the patient, to get them to understand they're in a more stable environment than the ED is at that point. So we've actually seen that help. It's just we've only done it a couple months now, but we've actually seen a little bit of a change with that. And so that is just one of the many things that we've been trying.
Yeah, so nurses have a lot of control, obviously, over when beds up on the wards are made available, right, for patients coming in from the ED. So you've seen some positive impact of having some of those nurses who have that control spend some time in the emergency department.
Correct. And that has actually worked. Like I said, it's really opened their eyes to that. But also getting the inpatient nurses and physicians to understand that throughput is everybody's responsibility, not just the emergency departments. And so even if all of our hospitalists can discharge one patient by 9 a.m., that could be 15 patients out your door by 9 or 10 in the morning to really create that pull effect versus the push effect. And at the end of the day, we're all there as one big team. It doesn't matter where your patient is at. We're all there to take care of those patients. So we need to really think about that from an organization's perspective.
That's especially well said. Thank you.
Thank you.
Eula, I'd love to turn to you. So adults ages 65 and older make up more than 20% of all emergency department visits across the country, so disproportionate to their share of the population. Are older adults more likely to be boarded, less likely to be boarded than younger patients? And what do we know about the outcomes of boarding for older patients?
Great. Thank you, Robin. So to highlight your point, boarding is a reason we're here as a summit, and it's a thing that patients of all ages experience, but disproportionately older patients experience it at a greater rate than others. I would really encourage all hospital leadership to really take a close look at their boarding numbers, and while the numbers are high, break it down and stratify and look specifically at your older patients. If you actually stratify, you'll see they actually are boarding longer. I've worked across 5 different healthcare systems, one including the VA, a big national one, most recently now at NYU, but previously at Mount Sinai and at Yale, and at a community hospital. And if you look at the breakdown, the oldest patients, 85 and older, I don't think there's a single one of the hospitals that I've worked at where the oldest patients boarded at a shorter proportion than younger patients. This disproportionately affects older adults because they're, as we heard earlier by Dr. Valdez, the longer patients stay, the greater the risk of mortality. And I think a lot of this stems from compounded exacerbations of existing conditions. It's the older patient that has more comorbidities, they have risk for dementia. This puts them at greater risk for delirium. And so we're compounding, or in many ways introducing an iatrogenic complication to maybe something, what we heard before with Rosie's story. It was a cellulitis, but it compounded and worsened, and her mother had dementia. She became likely agitated or had delirium, and then eventually this became sepsis. So these are things that we can do to reduce or mitigate the compounded risk, but the older patient is more vulnerable and at greater risk for these exacerbations, including 30-day mortality.
Yeah. And as someone who focuses quite a bit on care for older patients, how does ED boarding affect your ability to care for those older patients well, especially the ones who are frail, right? I mean, they're showing up at your doorstep already with a lot of health problems, as you mentioned, but what happens that's different for them or might have a disproportionate impact?
So you bring up the word frail, and I think frail is a really important consideration. Frailty is actually, a quick way to think about frailty is just age, but not everybody that's an older adult has frailty, and so frailty is also a mix of functional and comorbidities that may have, and so that benchmark in itself puts the patient at the greater risk for these negative outcomes. The frail patient is the one that in all likelihood is the complicated one. We heard several stories already this morning of the patient that may have dementia and likely many other conditions. Patients that are 85 and older are more than twice as likely to have some form of dementia or cognitive impairment. These are the ones that are now boarding longer in the emergency department. So we heard stories where they became more agitated. They weren't allowed to eat or have anything to drink for days, potentially. That was really quite long. But we're now being held to measures, CMS, geriatric ED, geriatric emergency departments, and now guidelines, or if you want to be accredited as a geriatric ED, they're being held to benchmarks of 3 hours or 4 hours. I don't think any of the hospitals that we've heard this morning were going to hit that mark. But the longer patients stay and the more frail they are, the more likely they're going to have these complications. And it makes it more challenging for the staff. We hear about staff burnout. You have someone spiraling and they're becoming unstable while in the emergency department. The nurses are strained with their ability to care. A lot of times we hear about patients boarding, especially the frail patient, because staffing upstairs say they can't manage the patient. But the ED is an even more difficult environment whereby we've got now the inflow of acute patients and we're managing these patients that are becoming agitated. And unfortunately, I heard a comment earlier this morning about giving Haldol to patients. If you give Haldol to the older adult, now you've just increased their length of stay in the hospital. So maybe what we should do is more preventively get them upstairs sooner so that they don't spiral and have progressive worsening. Compounding, spiraling, all complications that I think frailer older adults experience, but then also the staff experience, both in the ED and upstairs.
I'm glad you mentioned the giving sedatives. So not only are we making that patient worse, but then if we don't do that, that nurse who is, their time is taken up by that patient, now we're compromising care for all the others. There is nothing good about that situation. We should not even have to be worrying about what sedative to give this patient because they shouldn't be in the ED to begin with. So the fact that the geriatric patient is down there, it's bad for them, and it's also bad for their neighbors that nurse is taken care of as well.
Well, and also, Brandon, you raised the term moral injury to clinicians earlier, right? And that idea of prescribing a sedative to a patient who only needs it because of the surroundings, the situation they're in, when they could be in another situation. How does that impact clinicians?
Oh, it feels dirty. I don't like it at all. I don't want to give them benzos. I don't want to give them antipsychotics, but also I can't have them climbing the walls and putting themselves and staff and other patients in danger. So there's nothing good about it. It's the lesser of two evils.
Yula, you mentioned the CMS geriatric, I'm not going to get the name right, certification program? Accreditation, there we go. I always confuse the two. The geriatric accreditation program for the emergency department. So I believe that's a relatively new program. And I'm curious, when you say requires emergency departments to commit to 3 to 4 hour turnaround time for geriatric patients, what impact, first of all, how likely is it that emergency departments are going to be able to meet those standards given the current resources? But also, how does that impact care for other patients?
Yeah, well, so I think a couple of things that I'd like to really highlight. The geriatric ED accreditation program is new. It's relatively new. It started in 2018, but this has been long-standing work over decades of groups of geriatricians, emergency physicians. It's a team sport. Nurses are the front line. Pharmacists, social workers, physical therapists, really engaging and trying to advocate for the special needs of older patients in the emergency department. Criteria were set up really to establish best practices or recommended care, and the criteria continue to ratchet up. You can be all the way from a level 1 geriatric ED down to a level 3 geriatric ED, whereby limited resource rural hospitals can attain a recognition as geriatric emergency departments. Just this past spring in 2024, the accreditation criteria actually ratcheted up to really further emphasize greater metrics, including tracking of boarding. If you want to be a level 1 or 2 emergency department, geriatric emergency department, you need to be demonstrating that you're tracking boarding for your older patients and monitoring the rates and proportions that these patients may be boarding in the emergency department. And I think that this is going to for hospitals who want to achieve that recognition, they're going to need to now address and recognize that, well, maybe we need to do something and prioritize these patients. And I think it's a step in the right direction. What I want to highlight is even more exciting is CMS now is moving forward with inpatient recognition, whereby hospitals must attest to 5 domains of age-friendly care. And within that, one of the domains is specifically about addressing patients that are frail and interventions for them. Within that group, they actually recommend boarding tracking, and that's where, if you read the fine print, the hospitals will be asked to attest to if they're tracking less than 3 hours of boarding time, less than 8 hours for ED lengths of stay. But if you're now admitted, 3 hours for boarding. And that's a tough number for many of our hospitals because, as we heard earlier, about the strain, the limitations, the challenges. As we know, boarding is a hospital-wide problem. It's a system-wide problem. It's not an input problem, but it's an output problem for patients getting patients upstairs. But the patients upstairs, they're also challenged because they can't get them to nursing homes. They can't get them to the community and resources and facilities that really will allow for shorter hospital lengths of stay. So addressing those community needs, really building those stronger connections, and having hospital leadership like looking as a whole to how they can address this is what's needed.
Thank you. Because the importance of patient story is front and center here today and in much of the work throughout HHS, can you tell us a story of a patient or two, an older patient, with boarding and how you wish things had gone and how they actually went?
Yeah, I'm going to give you 2 examples. One actually, as I was hearing Rosie's story, it was very similar. One of the hospitals that I worked at, we had a patient who had dementia. This was an 87-year-old gentleman, has a history of dementia and also some cardiac and hypertension, multimorbidity, but was actually sent to the ED by their psychiatrist because they weren't having any medical issues, but the patient was displaying what are called behavioral and psychologic symptoms of dementia. So they were increasingly agitated at home, difficult for the family members to manage. So the psychiatrist sent the patient into the ED because they needed to have their medications managed by psychiatry. But we also know psych EDs, psych floors, mental, the aging floors, they are increasingly under strain too, and there are no beds there. So this patient ended up boarding in the emergency department for 3 days. While they were there, they were placed in restraints and they refused their medications. So while they were rounded on and were recognized, by the time the patient got to the bed, it was recognized that they were unstable and in AFib and RVR, rapid ventricular response, and need to be cardioverted. The patient ended up going to the cardiac unit, and so this is an example of an iatrogenic spiraling. What we saw earlier, the continuous compounding of something that really could have been prevented had the patient gotten up sooner and maybe prioritized. I know the inflow is limited and everyone's trying to get through that door, but we really need to get those that are most vulnerable and the older patient upstairs first.
Thank you. Do you all have questions or comments? All right. So much of what we've heard from Chris, from Brandon, and from Eula so far this morning would be visible in some data if we collected the right data, right? The surveys, we have surveys of nurses, surveys of physicians, tracking of emergency department boarding, looking at patient outcomes. But outside of an individual hospital or health system, we often have limited data on boarding to begin with, and then there are some things that can't even be seen in those data. So I'd like to turn now to Charity to have a conversation about your personal experience as a patient, and you bring that dual view as a patient and also as a researcher, right? Because your story is something we would never see in the data about boarding at all, right? So let me turn things over to you.
Sure. Thank you, Robin. I want to start off by providing the very outrageous stats around maternal deaths. So we know that here in the United States, despite spending the most on health care, we have the worst maternal outcomes, and that is across the board. However, for Black women, we are 3 to 4 times more likely to lose our lives due to pregnancy-related conditions. In 2016, I was pregnant with my first daughter. I was 30 years old. I had no existing conditions. The most I did was get my wisdom teeth taken out. That was the most. My daughter was born in February, and I found myself coming back to the hospital just 2 months later with symptoms very reminiscent of heart failure, I found out later. I had talked to my OB. Many folks who know me know I'm very outspoken, so advocating for myself is not usually a problem for me. And so I communicated my symptoms, including being very tired, literally could not go up a flight of stairs without having to take a break. I had a nagging cough that wouldn't go away. I couldn't lay flat on a pillow. I had nausea, and eventually I just lost my appetite. And so after seeking help from my OB, but not really getting very far, received a number of diagnoses, including the flu and postpartum depression, which were not the case. I made the hard decision after experiencing pain in my left arm radiating up to my jaw to go to the emergency room. Now, as a patient, at that point in time, I was a PhD student. I was well aware of what the symptoms were of cardiovascular disease. My mom and my dad both had heart failure. My mom had experienced heart attacks. I knew that this was serious. However, I also knew that an emergency room bill is not something I really wanted to add to that. However, I knew that I had to go. We made the hard decision to not call an ambulance because unfortunately many of us have to make the decision, how am I going to lower how much this is going to cost me while you're also thinking about your life? And so my husband drove me to the hospital where I have been receiving all of my care throughout my adult life, the same hospital where I gave birth. And I came in explaining that I had symptoms of what I thought was a heart attack. And we went through triage. I also told them I had given birth just 2 months before. And I received an EKG, which they told me, oh, that looks fine. You look good. Just go ahead and wait in the area. Just sit. And so I sat, and I sat, and I sat, and I sat some more, and I'm looking around the room, and I'm just seeing if there's anyone who's progressing in this emergency room area, and it looked like we were all at a standstill. And so for me, as a new mother who was breastfeeding, it was not somewhere where I could stay. So after waiting 5.5 hours with symptoms of a heart attack, I made the hard decision to go home. That was a very hard decision. I was scared, I was worried, but I was also worried about my daughter. And so what I found out just 2 days later, it was campus health, so also thinking about university-related health care, I found out that I had an enlarged heart. And when I was rolled, literally I call it a physical referral back to that same ED, I waited again for several hours after being told by the campus health physician that I had an enlarged heart. Waited again in the ED for hours, was finally admitted in the cardiac intensive care unit where my heart was functioning at around 5 to 10%. So, while Black women are 3 to 4 times more likely to lose their lives during pregnancy, I found myself in the category of severe maternal morbidity. But I was very close to being a part of that other number. And I thought very hard about what were the factors that made it where I had to wait so long. And I think this is a part of the experience of being a person of color in the United States. You wonder, if this had anything to do with my identity. As a social worker, I think about that as well. I think about social drivers of health. I think about what may have been some of the preconceptions that staff members may have had about me, kind of who are the gatekeepers in the ED in order to get the care that I needed. Maybe it would have been better if I came through an ambulance and just ate that bill. So those are some of the questions I had when I was admitted at that point. And I stayed in the hospital for 2 weeks after also having a negative reaction to a beta blocker, which was part of my treatment for heart failure. And so now at the age of 39, I've lived now 8.5 years now with heart failure. But it could have been very easily where I wasn't here at all.
Thank you for sharing that. So the reason I mentioned that this would never show up in any of the data is that the first time you went to the emergency department, you were never seen by a physician, right?
Never seen. Triage was it.
So no decision was made to admit you, even though clearly you needed to be admitted.
Very true, yes.
Yeah. So Brandon, Eula, Chris, I'm curious, having had a chance to hear what happened to Charity, what's happening for you all as clinicians on the other side of the equation while a patient who has this kind of experience is going through what they're going through?
To me, I'm aware of all the patients that are in beds in my treatment area that I'm responsible for. What terrifies me is what I don't know that's sitting in the waiting room that I'm also responsible for. There's so many case reports of bad outcomes of patients sitting out there waiting for hours on end. To untrained patients who don't know any better, they think we're just back there shopping on Amazon. We're busier than a one-legged man in a butt kicking contest back there. I mean, we're hopping. So can I say that on I don't know.
You just did.
I'm constantly eyeballing the waiting room. I'm looking at the chief complaints, the vitals. I'm pulling up EKGs. Sometimes a charge nurse will say, hey, I'm about to get a couple beds open. Who out there do you want to pull back? Not all charge nurses will do that, but I'm terrified constantly of the waiting room.
And if I can add to that, that is something from a charge nurse perspective that we try very hard, as we always do pull to full, but most of the time we're full by 10:30 of a morning, as most EDs are busy 10:38, about 3 a.m. But for that very reason, we make sure that we're pulling patients out that may be ready for discharge so we can put patients with fewer symptoms into a bed. But as you mentioned, our sickest patient is in that lobby, and we don't want them in the lobby because we need to make sure that we're always scanning that lobby at all times. I know a lot of hospitals are doing what they call PIT, which is providers in triage, and that could be a physician, it could be a nurse practitioner, or an advanced or a PA, for an example, working very closely with that triage nurse so we don't miss situations like this, because we don't want that to happen.
And I'm going to tie it right back. It's really awful to hear what happened to Charity, and I think tying it back to this conference, it was probably, my guess is a condition with regards to boarding. It was probably full in the back, and maybe a lot of those beds that she could have gone to were now occupied by patients waiting to go upstairs. And so these strategies where we've seen hospitals now moving PIT or moving a physician now into triage, physicians seeing patients in the waiting room. I've seen all of these solutions. It's a solution, it's a strategy that the emergency departments are trying to do, really to try to address the systemic issues again of what's going on in the hospital. And so really this is, the ED is a very resourceful environment, but this is a problem that really requires the system to address.
And Robin, if I can add a additional caveat. So that was before COVID. After experiencing COVID, I also had to go back to the same hospital, and I was very resistant to do that because in my mind, this is where I almost lost my life. But I also was experiencing some symptoms that were concerning for my heart, and so just less than a year ago, I went back to that same emergency room. We called 911 at home. I went in the ambulance because I knew that maybe this would help me get care quicker. But when I was brought to the ED, I was on the stretcher, I remember, from EMS. They were doing the transfer. And I was put in the wheelchair yet again and wheeled towards a wall. And I just sat there in a wheelchair facing a wall. And I heard my neighbor, because we actually coordinated my care before with my friend, my family and my neighbors. And my neighbor, we made the very clear decision that because she was a white woman, that maybe she can advocate for me. And so she came and had to find me because they could not identify who I was when I was in the ED. They said I was not admitted yet. So there's also this period of time with the transfer where you are almost non-existent yet as a patient, and there's a lot of room for things to possibly go wrong. I was diagnosed with pneumonia at that point, but it was my neighbor who had to say, she's right there. That's who I'm looking for. That's who needs care. It required her to use her identity in order to advocate for me at that point. And that is scary to think about, because I was lucky enough to have a neighbor who cared enough for me and my family to be there. But what about those who don't have that kind of resource?
For sure, and thank you for sharing that. And that sort of echoes to me what Brandon was saying about you had not one but two experiences of being in the waiting room where essentially no one from the clinical perspective knew you were there, other than in the first case a triage nurse. So before we turn to the audience and folks online for questions or what curiosities might you have for Chris and Brandon and Eula from your perspective, Charity?
Oh, I have a lot, and I'm trying to figure out which hat to put on because there's so many that I wear. One question that I do have is more about my profession as a social worker, and the conversation around social drivers of health has increased over the years, but this is something that social workers have been doing since the start of our profession, and I'm just wondering who's missing from the conversation around ED boarding. Who else needs to be brought in to improve patient care and patient experience? Is there a place, or how could we make a place for social workers, for instance, to serve in addressing some of these issues?
I was reading about the impact of community health centers on improving the number of patients that don't present to the ED for conditions that could be seen as an outpatient, and also giving opportunity upon discharge, because a lot of times the inability to get patients discharged from upstairs to appropriate, safe follow-up is a factor that contributes to ED boarding. Specifically, these communities that had community health centers had social workers and case managers who help coordinate a lot of that. Having someone like your role, who would basically be the conductor of patient movement, I think would be huge with getting these patients who otherwise would not have access to the system other than the emergency department appropriate follow-up before and after.
I'd like to add, I'm so delighted that you're here to speak really about the role of social work and case managers. I think they need to be at the table, and I think the example, Brandon, that you just gave is really one where this is having them serving on the inpatient floor to get patients, but actually having them in the ED is even more important, because there are so many patients that, many of these frail or complicated patients, that maybe don't need to be admitted for medical reasons, but they're admitted because we are concerned about their being safe for discharge, and suddenly now they're being admitted. The opportunity to have social work and case management earlier, why wait till they get to the floor for these transitions to occur? Just have it start as soon as possible in the ED. I've used to work with hospitals where they didn't have social workers in the emergency department, and increasingly we're seeing them utilized and brought in, and the better functioning EDs that I've worked at have a team of social workers and case managers, and they really need to be at the bedside, and they also need to be at the table for these discussions.
And I actually was going to add that that really is best practice, is to have social work and case management combination within the ED from the very beginning. So, for example, if a nursing home is sending a patient to the ED, a lot of times you can intervene right then and there, and they don't even have to be admitted from that perspective. So I think maybe from a critical access perspective, you don't see that as much, but you, in your larger academic centers and your community hospitals, we are adding those team members to the table because it's very important to have them in the ED from the very beginning.
Totally agree. I also think that social workers can probably catch individuals like myself who don't get to see a provider but also still need some kind of follow-up.
I'd love to turn to the audience and hear what questions you have. And who has the microphones? We're getting the microphones. So we'll bring the microphone to you, first in the middle. Frank, if you could go first, right in the middle, straight down in front. Yep, there we go.
Thank you so much for this incredible discussion. My name is Dahlia Risk. I'm in the Mount Sinai Health System. It's nice to see other colleagues here, and very important discussion. I'm hoping, because there are so many incredible thought leaders here, that we kind of reframe this, that output is not out of the ED, but out of our entire hospital and out of maybe even our systems, because I find that a lot of our discussions through this problem have been very ED-centric. I'm sorry if I offend anybody, but I'm a hospitalist chief, and I've seen the challenges that we face in throughput and discharge over, my entire career, 26 years as a hospital medicine leader. The moral injury that we experience trying to discharge patients, to get those patients up from the ED, is very challenging. Things that are systems-based that I heard in our introduction about payment models, 3 midnight rules, hospital at home reimbursements, PT as well as social work and case management in the ED to help with efficiencies. There's so many things that we need to think about, and you brought up very important alternative solutions, telemedicine, urgent care, and other things that we need to think about, how we're paying, how we're reimbursing, discharge planning in Department of Homeless Services, how we're trying to help our patients that we deeply care about. So I kind of hope that this entire meeting is reframing the problem from ED boarding to our entire system, and how we can create solutions so that we can actually move the needle. I'm here with representing Society of Hospital Medicine, not my hospital, so sorry if I offended any ED leaders, but I think it's really important to think about the system in general, because ED boarding is like the disease, and I think our healthcare system is focused on diseases and not prevention of diseases. So hope that's okay.
Thank you for sharing that. I don't think you'll offend anyone in the room by recharacterizing this as a hospital-wide or health system-wide problem, right? This is, it's very clear that the symptoms show up in the emergency department, but that is not the underlying cause of the challenge. So anybody would like to respond to the comments?
I'm always in favor of recognizing systems versus just one piece of the puzzle. And so I do think that we're pointing to a large issue that just not only needs to be restructured in how we think about it, but also how we approach it in identifying interventions. So I totally agree.
Thank you for your comments, and I'm excited to hear that a hospitalist is here, because the challenge, I think what we're hearing or what we're seeing is really a growing coalition of disciplines really coming together and really trying to work on solutions. My own background, actually, as a researcher, I started with ED crowding, again, not boarding, but crowding as a problem 20 years ago, and decided to focus really on the vulnerable patient and thus geriatric patient care. And here we are 20 years later. I understand this is the 3rd boarding summit. The solutions really we now need to come together and really work on this. I think post-pandemic, the whole healthcare system, but also the resources in our external communities are all at strain. Nursing home closures haven't helped, and it made it more difficult for hospitalists to get your patients discharged. And so really coming together and really making sure that our own health systems, our own institutions are well connected to the resources so that you can address it. I've seen variability across hospitals in terms of how they can address boarding, and a lot of it's because of their connections to the community.
Thank you.
So about 20 years ago, we moved from a 12-hour shift to a 9-hour shift. And now that I'm 60, I think maybe a 4-hour shift would be perfect. But I'm wondering, Chris or Brandon, are you aware of any research, any experiments comparing, let's say, a 4-day, 9-hour work week versus 3 shifts of 12 hours each, and the effect on burnout for nurses and doctors?
So I'm not aware of any recent ones. I do know that from studies in years past that it has proven that 12-hour shifts was too much, that 10-hour shifts actually, you had decrease in medication errors, decrease in any type of error with a patient, but I'm not aware of any recent ones right now.
Same, not any particular studies. My former chairs in the back of the room here, when I worked at an academic institution, we worked 8-hour shifts, and those were marvelous. I now work in a variety of facilities, 11 different ones, where my critical access hospitals are 24-hour shifts, where I might see 20 to 30 patients and just get nickel and dimed all night. And then I also work hospitals that I see about 40 patients in 8 hours or 50 patients in 12. It probably depends a lot on the volume. I am not a good doctor at the end of those shifts.
Yeah. Hi, Deb Dirks from UT Southwestern. I just want to, as I'm listening, I'm getting stuck at the fact and the idea that ED boarding is a disease. ED boarding is a symptom. It's a symptom of hospital occupancy issues. And when we think about who should be here, it really should be CMOs. You know, and EVPs of health systems, and all those people. And Brandon Carr, I know you're here. Thank you. But this is an occupancy issue, and boarding is a symptom of the fact that we can't get people upstairs. And so, I think as we discuss, the emergency department's not the problem. We're trying to find solutions every way we can, doing and taking care of patients in ways we don't think are ideal. Our nurses are overworked. Everyone's overworked and working as hard as we can because we can't keep getting people in, and we can't get people out. So we are a symptom, and this is a symptom of a broken system, but we are not the disease.
Thank you for sharing that. Absolutely. And again, to go back to the idea that this is, you know, if I had my way, I would stop calling it ED boarding, and I would start calling it hospital boarding. Anyone want to respond to that?
I would say also that community members who come to the ED for their care also need to be at the table for these conversations. And so if we can somehow create a space where CMOs and community members are at the same table, that would be amazing. I would love to be there just to witness that, because I think there's sometimes just a need for conversations to occur, and transparency sometimes can be one of the first elements of a solution. So if we're sharing information, have an understanding of what the problems are, where the problems lie, then maybe we can get one step closer to actually solving them.
So I completely agree, and I would say for everyone in here that's ED leadership and needs to take a message back to your hospital and CMO, also tying this back to their wallet. Length of stay, the new CMS measures that are coming out next year that they'll now be required to attest to, that's going to affect their ability. It's not, I don't foresee much further down the line that this now is subsequently becoming maybe a payment issue. So really bringing that to their attention, I think, will also now draw the hospital leaders to really listen and understand that this is a boarding situation of the hospital system.
Thank you. Peter.
Peter Vucellio from Stony Brook, at an emergency department where we admit 35% of our patients. Part of my commitment to this issue has been to argue that we need to offset the argument of there's too many unnecessary visits in the emergency department, and that our problem is that our patient population is too sick. So you had made mention of telemedicine and alternate places of care. That's fantastic. Mention of urgent care. That's fantastic. Preventive medicine is all fantastic. The problem for this topic is that those discussions create the sense that maybe the emergency department is the disease instead of the symptom. And if we can just fix that problem of unnecessary visits, There is a world out there that believes that our emergency department is brought to our knees by people with bee stings that just got one bee sting instead of stepped on a beehive. But I'm just curious as to your thoughts about this.
I think your statement is proven true when you look at the fact that none of these programs are working to reduce the number of patients coming into the emergency department. You're right, they are sicker. I think maybe with the exception of critical access hospitals, the average admit rate is going up because of the proportion, the higher acuity of these patients that are coming in. Personally, I would attribute that to the lack of outpatient primary care, preventative health. If patients are not getting their comorbidities managed on a long-term basis, they get out of control, they present when it's already too late. And so now we're having to manage that in the emergency department. I think strengthening the outpatient world where you can get more access to preventative care would make a huge difference.
I think we have time for one more question, please. Oh, wait, there is somebody right ahead of you. I'll see if I can get you in as well, but please.
I'm Asia Terry. I'm a practicing emergency physician here in D.C. at George Washington University. I'm the immediate past president of the American College of Emergency Physicians. I want to first thank HHS and AHRQ for convening this summit. I just wanted to respond to many of the comments around the language that we use. Certainly words matter a ton, which is why I kind of refuse to say ED boarding anymore, and I think we should call it hospital system overload, because essentially that is definitely what it is. And again, words matter a lot. Part of the problem is that boarding and crowding and hospital system overload has become status quo and really an expectation. When you go to the hospital, when you go to the ED, you're expected to have to wait. Part of the problem is that we haven't been able to put a face to the disease in the way of patients due to HIPAA and other limitations, privacy issues in terms of health care. And so once we put a face to it and see that this is really detrimental to outcomes and people are literally dying and spread that word, I think that we'll see the needle moved. Thank you.
Thank you. And I want to see if we can turn to just that one last question before we take a break.
Thank you so much. Barbara DePietro from the National Healthcare for the Homeless Council. We're part of the Health Center program. Curious your thoughts about how private equity and profit are either causing or exacerbating some of the problems that you're seeing, particularly in workforce and rural critical hospital access.
I think Dr. Carr may be able to speak more to that when he gets up here.
And apologies to the shareholders in the room.
I work for democratic groups as well as corporatized groups across my 11 different emergency departments that I work in. And I think the narrative around corporate practice of medicine, to be honest, is disrupting and harming the healthcare system. We are becoming a little bit more profit-driven, less patient-centric. Our performance measures are not patient-centered measures a lot of times. So, yeah, a lot of work to do on that. And I'm going to be quiet because I work for some of those people now.
I was wondering who would have the guts to even start answering that question.
I don't work for one, but so what I'll say is I do think they're attributing to the staffing shortages. You see a lot of these groups coming in, and then they're basically, the way they make their profits is by reducing staffing. And as you heard earlier today, that's part of the reason why we are having this healthcare system overload.
I want to thank you all. I want to thank all of our panelists. Our job this morning was to set up the conversations that are going to be happening throughout the day by discussing the impact of boarding or hospital overcrowding, or hospital healthcare system overcrowding. So we're going to take a break now until 10:50, and when I'll be joined on stage for a fireside chat with Dr. Brendan Carr. Thank you all.
Produced by the U.S. Department of Health and Human Services.